My name is Dr. Amer Raza. I'm a consultant gynecologist in London. My special area of interest is laparoscopic surgery or keyhole surgery and hysteroscopic surgery. Today I'm going to talk about a very common procedure carried out in gynecology clinics and gynecology department, hysteroscopy. Hysteroscopy is a common procedure which is carried out to check and diagnose problems inside the uterine cavity and also treat them. I can broadly divide the indications for hysteroscopy into two main groups. One is diagnostic and other is therapeutic. The diagnostic indications to do hysteroscopy will be to investigate for irregular bleeding, postmenopausal bleeding, to check for endometrial polyps, to do a fertility assessments, and also to check for fibroids as a pre-operative assessment. Hysteroscopy is also carried out if threads of the coil are lost and as a part of our cancer diagnostic work. The other big category for doing hysteroscopy is therapeutic, and that will include to remove fibroids from inside the uterus, to remove endometrial polyps, to treat adhesions and scarring inside the uterus, to remove or excise septums which develops due to congenital reason. At times it is done to take away or excise the endometrium lining to help with heavy periods or endometrial ablations. Hence, hysteroscopy is part and parcel of every gynecology department. I can divide the hysteroscopic technique into two main techniques. One is hysteroscopy under local anesthesia in an outpatient setting, or to have a hysteroscopy under general anesthesia in an inpatient setting. We will now talk about outpatient hysteroscopy. Outpatient hysteroscopy is a very common procedure and carried out almost in all hospitals now. It is the benefit of walking into a clinic, having the procedure done, and go home after few minutes. Hysteroscopy in outpatient setting is part of a diagnostic workup for irregular bleeding, postmenopausal bleeding, to rule out the possibility of endometrial cancer and also treat small uterine pathologies such as removing endometrial polyp, removal of a intrauterine contraceptive device or a Mirena intrauterine system, or even to do endometrial ablations and remove small fibroids. There are few key salient features for outpatient hysteroscopy. I will now explain to you about outpatient hysteroscopy, how is it carried out, and what are the things you need to know before having an outpatient hysteroscopy. One of the most important factors in outpatient hysteroscopy is the management of pain and management of expectations. Hysteroscopy is a procedure which can be painful for some women and can also have a degree of discomfort. I always advise my patients to take pre-operative, pre-procedure treatment with paracetamol and ibuprofen. Different hospitals will use different management for pain, but having some pre-procedure treatment with pain relief is a better option. Once you see your specialist, you may have other options also to have intraoperative pain relief with lignospan to numb the cervix. These pain options will definitely reduce the pain and discomfort, but still there could be some degree of discomfort. The main message I give to all my patients, the procedures is always in control of patient. In spite of all these options, there will be still a degree of pain or discomfort during the procedure. And I always assure my patients that the procedure can be stopped at any time if it becomes painful for them and they're not able to cope with it. Second common thing will be slight bleeding after the procedure. And third thing, some spasmodic pain after the procedure. There is also a risk of false passage as the camera is inserted. If the birth canal is tightly closed, then at times camera can make false passage. The risk of perforation is very small in outpatient setting. Initially, a diagnostic hysteroscopy is carried out in the clinic to see for pathology, and if any pathology such as endometrial polyp or septum adhesions are noted, then consultant will give you various options to remove these pathologies within the outpatient setting. Now we have instruments like TrueClear, Marshall, which can help to remove polyps and small fibroids within the clinic settings. Endometrial ablation such as NovaSure is also carried out commonly in the outpatient setting to help with the heavy periods. Marina IUS or copper coils can be inserted for either contraception or to help with heavy periods. You will expect some degree of pain and discomfort with a light bleeding after the procedure, but this will be self-limiting and will resolve soon after the procedure. In all childbearing age, it is best to have a single dose of antibiotic to reduce the risk of infection. However, the risk of infection is quite low in an outpatient hysteroscopic procedures. Now, in comparison, the alternative option is to have a hysteroscopy under general anesthesia. Given there is a general anesthesia will carry its own inherent risks. And there are some procedures which have to be carried out under general anesthesia, such as large fibroid uterus, extensive uterine adhesions, or even endometrial ablations in some cases. The risks of injury will be reported as 1%. The most common risk is uterine perforation. The risk of such injury is 1%, 1 in 100 operations. If uterine perforation happens with a camera alone, then a simple observation and antibiotic cover will suffice. But if perforation happens with energy attached to it or some sharp instrument attached to a camera, then it is best to do a diagnostic laparoscopy, which means a small 5mm camera is inserted through the belly button to look inside the abdomen to rule out any injury to the bowel or blood vessel during the process of hysteroscopy. Your surgeon will be explaining you all these things prior to procedure. The risk of uterine perforation is very low in outpatient setting. Along with all these general risks with hysteroscopy, there will be some specific risks associated with the procedure you are having. So, if you're having transcervical resection of a fibroid, your consultant will tell you risks of fluid overload in addition to risks of injury, perforation, pain, and infection. Lots of fluid is used. We use saline fluid to be able to see inside the uterine cavity and treat the pathology.